Hello, Professor. I hope all is going well. My name is Collette Moore, and I would like to welcome you to my oral soap presentation today. I am in my pediatric rotation this semester, and I am currently located in Rancho Cucamonga, California. I am working with a world-renowned pediatrician who is a author of many books, and he also has lots of experience in pediatric, over 30 years, and I consider him to be the pediatric guru. And I will be presenting a very interesting case that I ran into this week, known as phimosis. This is also known as tightening of the foreskin in males. This was very interesting to me because, number one, I have never heard of this condition, and I was quite curious by it. Number two is I was taken aback by this case because it can cause penile carcinoma. This case was very challenging in itself because the patient had a history of Down syndrome. It was challenging because he didn't know what to be expected, especially if he used to go to surgery. He wouldn't understand why would he have stitches, or why is it so painful, or why, it's so painful down there. So, identifying data on this patient is his initials are TT. He's 7 years old. He is a Caucasian male who presents to the clinic with his parents, who are both his spokesperson and are good historians. So, getting into the chief complaint, their chief complaint is that TT is spraying urine everywhere when he urinates. Okay, the HPI will further explain that TT is a 7-year-old Caucasian male who is accompanied by his parents to the clinic today, with complaints of TT having swelling in his genital area and spraying of his urine output. The mother reports that it started 1 month ago when TT complained of intermittent pain in his genital areas while urinating. The pain was moderate according to the Wong-Baker pain scale, and she states that the pain radiated to his abdomen. So the mother also reports associated redness, tightness around the area, and dysuria. However, she did deny any fevers, any hematuria, any foul-smelling urine, any discharge from the area, or any urinary frequency. The mother states that she has been giving him over-the-counter Tylenol to help with the pain, but it was no relief. Matter of fact, she said his symptoms have gotten worse this past week, so she brought him in for further examination. TT is up to date with all his vaccinations, and his last physical exam was on January the 1st, 2021. As far as his past medical history, he has a history of trisomy 21, which is Down syndrome. He also has a developmental language delay. He doesn't have any past hospitalizations. He doesn't have any past surgical history, and he doesn't have any allergies to any drugs, foods, or environmental allergies. Okay. His family history includes his mother, which is age 41, she's alive and healthy. His father, who is age 46, alive and healthy. His maternal grandmother, age 60, alive with a history of hypertension. His maternal grandfather, who is alive, 63, with a history of BPH. His paternal grandmother, age 65, is alive and healthy. His paternal grandfather, he's 68 years old with a history of dementia. TT mother report there are no other siblings and states there is no family history of cancer. The social history includes TT lives in a two-story house with both parents. He attends special education classes 5 days a week, and he goes to behavioral health therapy 3 times a week after school. Other than school, he travels to his grandparents' house because both of his parents are currently working. The mother reports TT is on a regular diet, but he is very picky and finicky about his food. He doesn't eat anything that has to do with green vegetables or green foods, and he likes to eat mostly finger foods like French fries and chicken nuggets and pizza. They do take him to the park on the weekend for exercise to allow him to run around. However, he does not socialize with any other children, and he doesn't have many friends. The mother reports that they do not smoke cigarettes, they do not use any illicit drugs, and they do not smoke alcohol. No one in the household does. And they practice a very safe environment. They wear seatbelts when they're driving, and they do not text while driving. And TT wears a safety ID bracelet that identifies his health conditions. She reports there is no weapons or domestic violence in the household, and the environment is pretty safe for TT. As far as the review of systems go, constitutional, she denies fever, she denies chills, she denies weight loss or weight gain. Eyes, she denies any redness, any swelling, any discharges, any itching of the eyes, any pain or vision loss. There are no vision changes, and she denies blindness. She reports TT's last eye exam was on January the 1st, 2021. His ear, nose, mouth, and throat. She denies any ear pain. She denies any ear discharge. Denies any hearing loss. Denies any loss of taste or smell. She denies any nosebleeds. She denies any trouble swallowing. Cardiovascular, she denies chest pains, denies palpitation. Respiratory, she denies cough, denies shortness of breath. Musculoskeletal, she denies any joint pain, denies any joint tenderness. GI, she does report abdominal pain. However, she denies any nausea or vomiting. She denies any diarrhea or constipation. GU, she reports dysuria. She reports redness. She reports swelling. She reports spraying of his urine when he urinates, and she reports ballooning of his foreskin area. However, she denies any urinary frequency, burning, or urgency. Okay, as far as his skin, she denies any rashes or lesions, and psych, she denies any problems with, she does report a problem with anxiety. Okay. As far as his social, his objective signs, his vital signs are normal. However, on physical assessment, his overall general, there was a noticeable developmental delay. The child appeared well nourished, he was well dressed, and he was sitting upright on the exam table, and his speech was slow for his age range. His head was atraumatic, however, it was microcephalic, and his hair was thin distribution throughout the head. His eyes, they did have that epicandric folds over the eyelids. He had small eyes for his facial structure. They kind of pointed upwards, and he had noticeable strabismus, and it was bilaterally. He had a positive red reflex, and his eye exam revealed 20/60 on the Snellen vision chart. His ears, nose, mouth, and throat. His mouth was very small. His tongue was protruding. Otherwise, everything else was unremarkable. Cardiovascular, it was unremarkable. Respiratory was unremarkable. His skin was unremarkable. And his musculoskeletal, he did have a very short stature, and he had decreased flaccid muscle tone. The GU was done by the preceptor and I, and we noticed that he was uncircumcised, that he did have ballooning of his foreskin around the area, and there was noticeable redness and swelling also. Neuro, again, he was developmentally delayed in both his language and his motor skills. The differential diagnosis I came up with was paraphimosis, which is a medical emergency of the not being able to retract the foreskin at all. And it was causing like problems with urination and almost causing necrosis. So that was not likely. Dysuria, it could have been because he was spraying urine everywhere, difficulty urine, but the problem was with that one he had other signs and symptoms, so that one was ruled out. The third differential diagnosis I had was balanitis xerotia obligatorum, which was a possibility, and it could have been a secondary problem from childhood conditions. The leading number one diagnosis I came up with was called phimosis. Phimosis was defined as what is phimosis? The impossibility of the retraction of the foreskin in males. So it just caused tightening around the foreskin area where, it cannot be retracted on its own. So the plan for him was to do a complete physical exam, which would help diagnose phimosis, which is the only defining factor that diagnoses it. And the plan was to send him to a pediatric urologist for this condition. Another treatment plan was to prescribe tropical steroid cream, which is clobetasol propionate 0.05% twice a day to be applied for 4 weeks. The reason why he needs to go to a pediatric specialist, urologist, is they might possibly plan for surgery for him. And the surgeries involved could be circumcision. So a pediatric urologist is more specialized in peds cases. They're more sensitive to their condition, and they won't be treated like they were going to an adult urologist, So education-wise, you want to assure the family that everything is going to be okay, and you want to teach them to do not forcefully retract the foreskin on that genital area, because it can cause it to tighten up more, and it can cause further damage, can cause the paraphimosis, and then this can be a medical emergency. And you also want them to follow up with the primary care physician in about 4 weeks to reassess. But if they were having a medical emergency, any fevers or any problems, you would redirect them to the emergency room. And if they have any medical emergencies such as shortness of breath, chest pain, or any other issues, then you would definitely have them call 911. Okay. As far as the Jean Watson theory, she was very ethical and very spiritual, and she believed that caring was the best thing for the healing environment. So, she spoke a lot about nurse being the primary vehicles of care, and she took a very holistic and spiritual approach to caring for the patient, and she liked a very quiet, caring environment. Okay. I would like to thank you for listening to my presentation, And if there's any further concerns, please let me know. And thank you.